Welcome to Delhi IAP and this academic initiative. As you are aware कि दिल्ली दिल है हिंदुस्तान का भी और दिल्ली IAP का भी दिल है. एंड डॉक्टर अजय श्रीवास्तव को मैं इंट्रोड्यूस करूं अगर तो इट्स अ प्लेजेंट ड्यूटी. ही इज अ गुड ओल्ड फ्रेंड. Central IAP is an executive director of Supetra Hospital, Raebareli. You know that Raebareli is very much in the news now these days. एंड रायबरेली के उस इनकम्बेंट से ज्यादा मशहूर पीडियाट्रिक्स में अजय श्रीवास्तव हैं. आई कैन से दैट.
क्या बात है सर.
ही इज अ सीएपी वाइस
जर्रा नवाजी का शुक्रिया.
नहीं, हमारे को तो रायबरेली का नाम आता है तो अजय श्रीवास्तव ही याद आते हैं.
नेचुरली सर, नेचुरली, बिल्कुल ये आपका प्रेम है.
And he is executive member of he has been executive member of CIAP in 1920 and 23, and he was honorary state secretary of UP state in 21-22, and he has been also in various chapters and sub chapters and everywhere. And moreover, he is also christened as entertainment king of IAP. He is always conceives good entertainment programs for any entertaining evenings. We had a pleasure of attending so many innumerable pleasant evenings in his patronage. And our chairperson, another ace academician today, is Dr. Virender Khanna from Gangaram Hospital. तो अजय प्लीज, हमारा इसमें यही इनिशिएटिव होता है कि वी हैव दिस वीकली पीजी क्लास एंड वीकली फैकल्टी लेक्चर प्लस एक ई न्यूरोलॉजी कोर्स है इन एवरी संडे. दीज 3 एक्टिविटीज वी आर डूइंग एवरी वीक ऑन प्लेटफॉर्म ऑफ दिल्ली IAP, और बाकी अपनी रूटीन जो बाकी स्टेट्स जैसे करती हैं कर रही हैं. एंड डॉक्टर खन्ना is a pillar behind this Institute of Child Health. Gangaram is a pioneer, maybe 80 years old institution with roots in Lahore, Pakistan, and then Gangaram Hospital was set up in Delhi, and ever since then you will find a ex-Gangaram person everywhere in every premier institution or place in all over the country. Ex-Gangaram ka banda milega. And today's our resident Gaurav Arora has done a lot of labor in preparing a talk today. I will अजय आप कुछ बोलें पहले, फिर डॉक्टर खन्ना आगे लेते हैं बात को.
Sure sir, sure. Thank you sir, and good evening. And it's really my great pleasure to be here in this important session of PG clinics. जब डॉक्टर भंडारी सर हैं तो निश्चित रूप से कुछ ना कुछ आपके कार्यकाल में ऐसा कुछ अद्भुत होना है, कुछ नया होना है जो कि आने वाले काफी लंबे समय तक याद किया जाएगा निश्चित रूप से. एंड आई हैव वेरी फॉन्ड मेमोरीज ऑफ विथ यू इन ऑल आवर EV मीटिंग्स एंड अदरवाइज टू. और आपका जो प्रेम जो दिल्ली मुझे कई बार आपने मौका दिया अपने लोगों के बीच में आने का और अपनी बातें रखने का. आई एम रियली ग्रेटफुल फॉर दैट. And today's program is also, it's a very good learning opportunity, and it is also a reminder of our commitment of providing the highest standards of care and support to patients like thalassemia. As I know today is a case of thalassemia. This is really despite all the medical advances, it's still challenge for a common pediatrician, and I think that today's session will throw some good light to how to manage that, and will bring out some unanswered questions too. So I extend my gratitude to all our presenters and experts who will be sharing their knowledge and experience with us today. So thank you very much, and I won't take much time. I wish all the best, and for your future endeavors too. So over to you, Dr. Bhandari sir.
Thank you sir, thank you. And Dr. Khanna sir, please अब आप take over the mic. And
thank you, Dr. Bhandari. Today we are going to discuss case of thalassemia, and that too non-transfusion dependent thalassemia. Till now, some time back, people were mainly concentrating on transfusion dependent thalassemia, thalassemia major. And that time, about say 20 years ago or 25 years back, people used to consider non-transfusion dependent thalassemia or thalassemia intermedia, what we used to call that, a benign condition. a milder condition. But now we know that this is not that benign. It is a totally different type of entity which has got a lot of complications, which as these children grow, it gives a lot of complications. So it needs to be picked up early at the early stage. Then these children need proper monitoring. These children need proper management. They need even chelation also. Everything they need. And today, Dr. Gaurav Arora is going to present a case of anti-DT. Let's start with the case, Dr. Gaurav,
Yes, sir.
and then we'll
Thanks.
discuss later.
Yeah. Thank you so much, sir. Good evening, everyone. I'm Dr. Gaurav Arora, second year DNB resident in Department of Pediatrics. And I'll be presenting a case of 12-year, 10-month male child, with the informant being father and religion Hindu. They are resident of New Delhi only, and the date of examination was 22nd of June 2024. So the child came with complaints of easy fatigability for past 3 days. The patient is a known case of hematological disorder, diagnosed at 2.5 years of age, who is on transfusion every 4 to 6 months, and came with a complaint of easy fatigability on doing daily activities, which is relieved on taking rest. So there was no history of palpitation, swelling of body, decreased urine output, or breathing difficulty. No history of jaundice, pica, worms in stools. No history of blood in stool or vomiting. No history of bluish spot on body or any rash on body. No history of leg ulcers or limb pain. No history of visual disturbances. No history of seizures, weakness of any limbs. And there's no history of bony pains, painful episode in chest or abdomen and fingers. Past history. There was no history of any surgery in the past. And the patient is receiving blood transfusions from 2.5 years of age, receiving blood transfusion every 4 to 6 months, and he's on capsule hydroxia from 2.5 years of age. The family history is a third degree pedigree chart, and both child is first born to a non-consanguineous marriage, and there was no history of similar complaints in family, any blood transfusions in family, or any surgery in family. There was no history of tuberculosis in family, and father and mother both are thalassaemic minor. On the mother's side, all there are three siblings, and all three of them are thalassemia carriers, and both parents are also thalassemia carriers. Antenatal history: mother age at marriage was 26 years, and mother age at conception was 28 years. Conceived spontaneously after 1 year of marriage, and there was no screening done for thalassemia during antenatal period. Or the rest of the antenatal period was non.
Yeah, in general, Dr. Gaurav, there's no need to go in such a detailed birth history or antenatal history for a child who is 12 years, unless it is directly related to the case. Okay?
Yes.
Right.
Natal history: delivery mode was normal delivery. A birth weight was 3 kgs. Baby cried immediately at birth. There was no history of nursery admission or any neonatal jaundice. Developmental history: it was appropriate for age, and now child is going in 7th standard with average scholastic performance. Immunization history: child is immunized up to date according to national immunization schedule. Socioeconomic history: belongs to upper middle class according to modified Kupusomic classification. Dietary history: the diet is calorie deficit by 4%, and child is taking protein adequately. So to summarize, a 12-year, 10-month-old male adolescent who was diagnosed to have a hematological disorder at 2.5 years of age, and who is on regular blood transfusion every 4 to 6 months and on capsule hydroxia, with mother and father being thalassemia minor, with no significant birth, developmental, or immunization history, and has come with complaints of easy fatigability for past 3 days.
Okay, let's go to the first slide. Dr. Ajay, you want to ask him anything at this stage?
No, sir. Please carry on.
Okay, we'll start with this easy fatigability.
Yes.
What do you think is the cause of this easy fatigability?
The easy fatigability could be because of anemia, or because of any chronic heart disease, or it could be because of
No,
any.
don't jump to heart disease for a child who blood transfusion every 4 to 6 months. Any other cause? Any deficiency?
Nutritional anemia, nutritional
Deficiency.
causes, malnourished child. But
Yeah.
for 3 days, it would not be
A
acute.
child who is getting regular transfusion every 4 to 6 months, top-up transfusion, and is complaining of easy fatiguability, first thing which will come to your mind is
Anemia.
low hemoglobin.
Yes, sir.
Okay. Next.
Yes. You can skip this because it's the same thing.
What was the presentation at 2.5 months, 2.5 years? What was his presentation? How was he diagnosed at 2.5 years?
So at 2.5 months, he had some febrile illness, after which the child remained very lethargic and was not very weak. So the parents got him evaluated and they found out he has severe anemia, for which workup was done, and later he was diagnosed with the disease.
What could be the cause of anemia at 2.5 years?
Sorry, sir.
You not examined the child.
He has examined, but probably it will come in later slides. And
yes, sir.
Yeah.
Causes of anemia
No,
in 2.5
at the
years.
time of 2.5 years, I'm asking him, what are the possible causes of anemia? What comes, the most important cause?
The nutritional cause is the most important at this age,
Okay.
because mostly children are milk fed,
Yeah.
and other causes could be because of infections.
Infection has in fact precipitated at that stage, that fever precipitated that this anemia increases the degree of anemia. Doctor. So that's possible in young children or infants when they present with anemia.
Sorry, sir, your voice was breaking.
I'm asking what are the other possible causes of anemia at
So
that stage?
could be because
One
of
is nutritional, hematological. Hematological में
Other-
कौन-कौन से आएंगे?
So hematological, we can have extracellular causes like autoimmune mediated or vitamin E deficiency, or we could have intrinsic causes in which we could have membrane
Vitamin
defects.
E deficiency. You'll think of, yeah. Generally, these membrane defects, enzyme defects, they are rare, and you think them once you have ruled out the common causes. Think of common causes first.
So blood loss could be there.
Yeah. Or,
because hemolysis, causing hemolysis, or inadequate production because of vitamin B12, folic acid deficiencies.
Yes, vitamin B12 again is a common thing. Or
Bone marrow failures would
yes, before that,
storage, infiltrative storage
if I say that
disorders.
he has got hepatosplenomegaly, yes, storage they will generally present early. Bone marrow failure syndrome, or among the hematological disorders, congenital hereditary spherocytosis may present, sickle cell may present with anemia, but they will present with episodic anemia. They have history of jaundice at birth, and sickle cell will present with history of dactylitis or pain or chest syndrome or pain abdomen, and hereditary spherocytosis.
Autosomal dominant.
Autosomal risk. Yes, it is the autosomal dominant. So there will be family history of that, family history of splenectomy or gallstones operation and jaundice at birth, and then other things.
Yes,
and then congenital, this is a thrombotic anemia or this thing, bone marrow production defect. They are rare cases, and then they can be diagnosed only when you do the bone marrow and all those procedures. Otherwise, many of them will have limb defects or absence in thumb or other defects, skeletal malformation.
Yes.
Okay, now we go back. Probably he's got low hemoglobin, and since he's been on transfusion, and at that time he was diagnosed as a case of thalassemia, as a case of hematological disorders. So among the hematological disorders, which one do you think was the possible cause at that time?
The thalassemia could at after 2 years of age, thalassemia intermedia is more common.
What is the definition of thalassemia intermedia? Now you yourself asked for it.
So if the child is getting less than 6 transfusion in 6 months, then it is thalassemia intermedia. And
That you have read, I know, from the latest TIFF 2023 edition of the book, but earlier we used to consider it as less than 9 transfusions, 8 or less transfusions per year. Now the TIFF latest book, I know you have read that. In that it is mentioned less than 6 transfusions in 6 months. But remember, thalassemia intermedia is a clinical diagnosis. If a child is diagnosed after 2 years of age, and then during that 2 years, he was maintaining reasonably good hemoglobin. By reasonably good hemoglobin, we mean that he was maintaining hemoglobin above 8 grams. Then we label him as thal intermedia, or the new terminology nowadays is NTDT, non-transfusion dependent thalassemia. Okay.
Yes,
in the negative history, quickly go through the negative history and just tell me, why did you ask all these points? But
so I've asked no history of palpitation, swelling of body, and decreased urine output to rule out any congestive heart failure because of anemia. I've asked jaundice to rule out hemolytic anemias, and pica to rule out nutritional anemias, worm in stools, blood in stools, and vomitus to rule out blood loss causes, and bluish spots on body to rule out any bleeding disorders, and rash for any autoimmune disorders.
Bleeding disorder, why? Yeah.
So hemophilia, because
hemophilia will not present like this. Hemophilia will not get repeated transfusions like this. Do you give blood transfusion repeated to hemophilia or something else?
No, so factors.
Yes. Then why do you think of hemophilia? Okay, now
blood loss.
Bluish spots, you asked for what? Hematological malignancy. No, a child will not continue with malignancy from 2.5 years to this age of 12 years. Anything else? Why did you ask for Caesar?
So in sickle cell anemia, because of vaso-occlusive crisis, Caesars could be there.
Vaso-occlusive crisis you can get. Or swelling of the limbs, dactylitis, history of repeated dactylitis, or
leg ulcers.
Yeah, episodic. Bone pain or painful episodes in the chest. Okay. Leukemia will not continue for such a long time.
Yes, sir.
See, his problem is for 10 years and he's been getting repeated transfusions. So malignancies cannot continue like that for such a long time, nor the infections can continue. Okay. Now, next. Hydroxyurea you can mention, but in this case he has been on some medication. It's better to say like that for the last 2.5 years, unless the mother shows you the medication itself. Okay.
Yes.
History of surgery. Which?
So splenectomy or cholecystectomy.
Yeah. Okay. Now next. In such cases, you can say in the present history that history dates back to 2.5 years when child was diagnosed as a case of hematological disorder, and since then he's been getting regular blood transfusion every 4 to 5 months till this age, and he has been on some medication for that.
Yes.
Okay. Family history, always give 3 generations in the pedigree chart, and this thing. The patient consultation you should label as white or normal. How do you label normal? You've given up.
White box.
So it is it is not. It should be dark box. No? This is the affected child.
Proband.
Yeah, proband. Okay, next. You should always ask for history on both sides. History of repeated blood transfusion, or surgeries, or history of jaundice or gallstones, or like that. Okay. This antenatal we can skip, except for antenatal. The only important thing is birth is. Can thalassemia present at birth?
No, sir. Well,
Why?
after 6 months only, because HbF is
Why does
high.
thalassemia present after 6 months of age?
So fetal hemoglobin is high
Yes,
after birth.
yes. You are right. Fetal hemoglobin continues. The fetal switch off takes place at birth, and gradually it weans off, and the adult hemoglobin takes up. So if adult hemoglobin is not formed, it is defective in beta thalassemia. Which type of thalassemia is common in North India?
In North India, sir. Sorry,
Yeah.
sir.
In North India, which type of thalassemia do you see? Beta alpha or
Beta thalassemia.
hemoglobin E? Beta thalassemia is commonly seen in this. Antenatal, you skip. Okay, next. Go ahead. Okay, next. This is okay. Should mention in short all these things. And before that, what was the slide before that?
Yes, sir.
Before this, dietary history belonging to Kupuswami. What are the criteria that you take in the modified Kupuswami classification? Did you actually do it?
Yes, sir. I have asked parents about it.
3 things you consider. Which one?
The occupation, education, and family income.
Of
Head of the
occupation
family.
of, yes, and family income and education. Okay,
Education.
next. Yes. What is the one important vaccination other than hepatitis B, which you should give to thalassemia? What are other
Well, Haemophilus influenza, H influenza, and Neisseria after
Okay,
splenic.
that is more important.
Before
Yes,
splenic.
for splenic cases. Hepatitis A vaccine.
Hepatitis.
A vaccine. See, you should always give hepatitis A because ultimately their liver gets affected with the repeated transfusion, and chickenpox vaccine also you should give them. Now, okay, that restrict comes next. Go ahead, summarize. So you have a 12-year-old child, adolescent, who was diagnosed as a case of hematological disorder at 2.5 months and is on regular. What is the possible thing that you can think of at this stage, with both parents being thal minors?
So most likely it is thalassemia intermedia only, because both parents are carrier. And child is on
See, you can't
hydroxy.
say intermedia at this stage. See, what was the hemoglobin when this child was diagnosed at 2 years and 6 months?
So it was around 5.6.
If I say, Dr. Gaurav, that he had hemoglobin of 6, 7 and parents didn't give infection or did not pay any attention, and he was diagnosed at 2.5 years, he presented because of fever, then he doesn't fit into that criteria of thal intermedia. So at this stage, you cannot say whether he's thal intermedia or no, but he's got a hematological disorder, probably thalassemia, and then we'll see on examination. Next, go ahead with the examination. Differential diagnosis, you're given. Go back, previous slide.
Yes.
Hemolytic anemia, non-transmitted, the possibility sickle cell and congenital dyserythropoietic anemia. Congenital dyserythropoietic anemia is a very rare condition, and you think of this condition only when you have ruled out the common causes of this. It can present any time, but type 2 is a common congenital dyserythropoietic anemia. Type 1 usually presents very early in life, and it has got skeletal malformation. Even type 2 has also got supranumerary toes and all those things sometimes. Okay?
Yes.
Next. Go to.
So on general physical examination.
But in this, I think you should have included hereditary spherocytosis, because he's intermittently getting transfusion.
Yes, sir.
So if he's getting transfusion, okay, from the history point of view, you should then quickly go through the general examination.
General examination, child is averagely built, conscious, oriented, alert, active. Vital temperature is 98.4
And
degrees
one
Fahrenheit.
thing important, you did not ask for their ancestral place of origin. That is
Yes,
also important for thalassemia. He is a resident of Delhi, but he may be belonging to migrated. His family
Mm.
might have migrated from Pakistan, or he is a Punjabi caste. And ancestral place of origin is important for thalassemia management. Okay, go ahead.
Yes, sir. The periphery is a warm pink. Heart rate is 112 beats per
Okay,
minute.
fine.
Respiratory
Go
rate
to
is
the
20.
relevant points now.
Yes, sir. Anthropometric. The weight of the child is 37.5. Expected weight is 39, and the inference that is 25th to 50th centile. Height is 149 centimeters. Expected is 155 centimeters. That is 10th to 25th
Yes.
centile. And the BMI is 16.6. Expected is 17. The maternal
Okay.
height was 154 centimeter, and the father's height is 160 centimeter. And the range the child should fall in, according to mid-parental height, should be 157 to 169 centimeter.
Remember that child is not grossly retarded here. He doesn't have grossly low height or weight. We'll
Yes, sir.
discuss it later when we put him on treatment, why we have put him on treatment. Okay.
So this is
He's maintaining within the
10th.
range, though on the lower side.
Yes, sir.
Okay, right. Next.
The pallor was present. There was no icterus, clubbing, cyanosis, lymphadenopathy, edema. On head-to-toe examination, conjunctival pallors were there. Facies were normal. Oral cavity was normal. There was no signs of any vitamin deficiency. Neck, there was no, and axilla, there was no lymphadenopathy. Chest was normal with no sternal tenderness. And genitalia, sexual maturation rating was, staging was at 1, that is prepubertal. Spine was normal. On skin, there was no rash, petechia, or purpura. And nails were normal with no
Okay.
signs of vitamin deficiency.
How do you check that this thing prepubertal in a male child?
So there was no enlargement of, well, the first thing is increase in the testis volume and development of
Yes. How do you measure testis volume?
so through
I'll show you. This is the orchidometer. This has got two colors. One is green, and this is the original orchidometer of wood. Nowadays, you get plastic orchidometers in the market. Okay, you measure with this. Did you measure? Do you have orchidometer?
No, sir.
Then how are you saying that it is prepubertal? You should always carry one orchidometer and buy it. It's not very expensive, right?
Yes.
And you said that faces are normal. You are thinking of thalassemia. What are the faces that you expect in a case of thalassemia, and especially intermedia, who is not that frequently transfused?
I'm saying facial
I know
changes.
nowadays we don't see those who are managed properly right from the beginning. In thalassemia cases, we don't see those typical hemolytic or thalassemia faces that we used to say. Okay, tell me.
So
what are the faces? What do you expect in them?
Malar prominence, frontal bossing, depressed nasal bridge, malocclusion of teeth, parietal prominence is also there.
Yes. That used to be called hot cross bun appearance of the skull. If you take the X-ray, and then you will see those hair and the end appearance in the X-ray. Okay,
yes,
next we go to the systemic examination.
Yes, sir.
Yes.
So on per abdomen examination, inspection, the shape was normal, flanks appear normal, umbilicus was center in position, there was no discharge, umbilicus shape was normal, abdominal movements were normal, there was no visible pulsation or scar, the skin over the abdomen appears normal, there was no distended veins, anal orifice were normal, and genitalia were normal.
Why are you saying no distended veins?
So on inspection only this.
Probably you're thinking of cirrhosis and portal hypertension. Okay, then next.
On palpation, abdomen feels soft. On palpation, there was no tenderness, no local rise of temperature. There was a palpable swelling felt 4 centimeter below the right costal margin, suggestive of hepatomegaly, which was soft with round margin and smooth surface. and there was a palpable swelling felt 8 centimeter below left costal margin, suggestive of splenomegaly, which was also soft, smooth, and non-tender. On percussion,
Okay.
resonant sound were heard. There was no shifting dullness, and liver span was.
Okay. Yeah.
Yes.
Right. How much liver span do you expect at 12 years?
So at 12 years, it's around 8 to 9 centimeters.
So it means the liver is enlarged, and you are saying that it is grossly enlarged on palpation also. And spleen, how do you measure spleen? From which place you start palpating spleen?
From right iliac fossa, we start from right iliac
Yeah,
fossa.
yes. That is the ideal thing. And there are other two methods also, that
Insinuation, Middleton insinuation method and right
and
lateral
then,
decubitus.
yeah, but standard is to start from the right iliac fossa and go towards the lower end of the ribs. Fine.
Yes.
Okay. Next.
The respiratory system examination, there was no significant finding on respiratory examination.
What were you expecting?
So because of anemia, there could be, because of congestive heart failure, there could be pulmonary edema. But
Do
in
they get congestive heart failure? You are thinking of thalassemia intermedia. They get right side heart failure because of pulmonary hypertension. They don't have cardiac cirrhosis. It's siderosis. Okay. Left side heart failure is not seen. It is so you get easy fatigability on walking, because respiratory distress on walking because of the increased pulmonary hypertension. Okay. Spine, everything is okay. Right. Next.
CVS examination, it was also normal, sir. There was no findings.
Did you check JBP?
Yes, sir. It was not raised.
Okay. Right. Oh, next.
CNS examination, child was conscious, no focal deficit or motor examination was also normal.
Okay. Fine. Next.
So on
Hemolytic
examination,
anemia. Probably non-transfusion dependent anemia, because why I'm now saying non-transferable, or earlier also not considering presentation at 2.5 years, otherwise also, because he's not requiring very frequent transfusions. A transfusion dependent hemoglobin, you yourself said that it will require more than 6 transfusions in 6 months. He's requiring top-up transfusion only in once in 4 to 6 months. So he's behaving like non-transfusion dependent anemia. Fine?
Yes, sir.
If a case of thalassemia comes to you after taking blood transfusion, how do you confirm the diagnosis? Anyway, now let's go ahead with the approach. How do you confirm the diagnosis at 2.5 years?
So I have investigations that were there 2.5 years.
Yeah.
The hemoglobin at 2.5 years was 5.9 with TLC of 12,000 and DLC of 35% neutrophils, 58% lymphocytes, and platelet of almost 3 lakhs, and total RBC count of 3.28 million, and MCV of 55.7 femtoliter, and MCH of 17.9 picogram, and MCHA of 32.2%.
I'll give you a clue that many times when you diagnose thalassemia, the first CBC you get a very high TLC count. That is because of your Coulter counter takes nucleated RBCs as WBC.
Yes, sir.
So you have to ask for
corrected
TLC. Yes. Surprisingly, in your case, it is 12,000. Fine, we accept it. And
corrected TLC was 8,000.
Yeah, TLC RBC count is low because most of the cells, when they are produced, they die at the maturation stage only. They don't reach the stage of reticulocytes and all.
Yes.
Okay.
Yes, sir.
Yeah, they have written corrected TLC here, 8,000 of that.
Yes, sir.
Okay. And what do you see in peripheral smear?
In peripheral smear, sir, we have anisopoikilocytosis, polychromasia,
Okay.
microcytic hypochromic cells, basophilic stripling, target cells, nucleated RBCs, normoblast.
Teardrop cells
Teardrop
also
cells.
you get. They
Teardrop.
look like a teardrop. And target cells, what are these target cells? Have you
So
seen
these are,
target cells?
yes,
They
sir.
look like a target, actually, what you
Bullseye,
see
sir.
in that board game. They
Bullseye.
look like that. Yes. Why? What is the reason for that target cell?
So because of differential staining
Because
of hemoglobin.
volume and surface, yes. No, because the surface of the RBC is more than the volume of fluid in that. So when you put it on the slide, it settles in the center, that hemoglobin portion, and it settles outside in the periphery. So you get a shape of target in that. Okay?
Yes,
now,
sir.
coming to HPLC report, confirmation is always by HPLC. See, your mental, what is the difference between iron deficiency anemia and this thalassemia minor? How do you diagnose thal minor?
So in
You said
thalassemia,
parents are thal minor.
yes, sir. So in HPLC, HbA2 level would be more than 3.5 with normal HbA and
No,
HbA.
not, you don't go straight away to HPLC. You see in the CBC. What is the change in the CBC
So there
in
would
thal
be
minors?
mild,
Quickly tell me.
mild anemia would be there of
Yes.
8 to 10 hemoglobin. And
remember, anemia is no way to diagnose thal minor. Some of the thal minors may have 14 and 15 also hemoglobin. So it
yes,
is not the criteria to diagnose thal minor.
yes, sir.
Only thing it is, in majority of the cases, hemoglobin is between 9 and 11. What else do you see? You
So,
are saying microcytic hypochromic, then MCV and MCH are low. What
low.
is Menzer index?
Menzel index is MCV by total RBC count.
Yes, and it is less than
13 in thalassemia and more than 13 in iron deficiency.
thalassemia minor, don't say major.
Minor. Yes, sir. Thalassemia minor.
In major, it is not applicable. It's only applicable for thal minor. And how do you differentiate it from iron deficiency anemia?
Sorry, sir.
How do you differentiate it from iron deficiency anemia, which is the commonest type of anemia?
From Menzer index, and we'll see RDW values, and total RBC count would be decreased in iron deficiency anemia.
RDW is
RDW will
what
be
happens to
increase in iron deficiency.
RDW. Yes, RDW is increased in iron deficiency anemia. Why it is normal in
thalassemia minor.
thalassemia, or what else?
RDW, RBC minor.
I'll give you a practical clue that
Serum
if
iron.
see, MCV, MCH in iron deficiency anemia is proportionately decreased. Like if you have 9 grams hemoglobin and the MCV is say 70 and MCH is 4. Hemoglobin is say 6 grams, then the MCH will be proportionately further down, maybe 60, 55, like that. While in case of thalassemia minor, MCV and MCH are disproportionately low as compared to hemoglobin value. Hemoglobin you may find 10, 11, and MCH may be 60, 65, and MCV may be maybe 60, 65, and MCH may be 15, 17, 20, like that. So it is disproportionately low.
Yes, sir.
Okay, just off this discussion, I'm asking, if gynecologist brings you up that she has got a lady pregnant with thalassemia minor, can she give iron or not? Medication.
She can give, sir.
Yes, very good answer. Very good. Because thalassemia minor is not an iron loading condition. Thalassemia minors can develop iron deficiencies. They should be given, if they have iron deficiency, they should be given iron. Okay, we go back to the case now. Fine. Generally, in Thal major cases, you find hemoglobin F in the range of 90-95% after the age of 6 months to 1 year,
Yes.
because they present at that age only. A2 may or may not be raised in all cases of Thal major. Okay, fine. In your case, it is 49%. A is this. So it means hemoglobin A is also being formed. F is also being there. Is there. A2 may or may not. In your case, it is raised. Okay, next. Quickly go through. Okay, that is more important.
Yes, sir. So we
SS.
did a
Yes, speak.
mutation analysis for the child,
Yes.
and it was
Yeah.
positive for CAP1 mutation.
What is CAP1 mutation?
So it is a silent mutation.
Yes. How many types of mutations we know for thalassemia today?
So more than 300 type of
Yes,
mutations.
you're very good. Very good. More than 300 mutations we know of thalassemia. Some are beta positive. Beta positive means
There is some production of
some production. Beta plus plus means more production of, and beta 0 means there is no production.
no production.
Okay. And what is this capsite-1 mutation? Do you know whether father or mother who is silent carrier?
So genetic mutation was not there for father and mother, but we have
Both are
C
Thal minors. Fine. Okay. Now you do the Menzer index and all that, you will find the whole thing which I told you. Okay. What is the significance of this capsite-1 silent mutation?
So in this, child would be asymptomatic also without any symptoms. The hemoglobin would be normal.
If he has inherited a beta plus mutation, he may behave like independent like this thalassemia, like your case. Fine. But otherwise, the significance is that capsite mutation is commonly seen in North India, especially in Punjabis. 2%, more than 2%. They say that it's up to 3.2% of Punjabis have capsite mutation. And secondly, it's again common in Pakistan also. So these are the cases who do not have MCV, MCH low. Their hematological parameters are normal. They may have normal HbA2 value. You may miss them on screening. That is the relevance, most important thing about this mutation. Like in your case, even if the test was done, you would have missed.
Yes.
Fine? Or, and then it makes the condition milder. Fine?
Yes, sir.
That's why. What are the other conditions which make thalassemia major or double heterozygote or homozygote present like Thal intermedia or non-transfusion dependent thalassemia? What are the other conditions? Tell me.
So, compound heterozygote condition like HBE beta thal and
yes, the HBE is a sort of abnormal hemoglobin. In which part of India do you see HBE more common?
Northeast.
Yes, East.
East.
Mainly in East, Northeast, you find more common. Bengalis. What is the incidence of thalassemia in India? Average prevalence of thalassemia?
Don't know, sir.
You don't know?
Yes.
Don't tell me. It is on an average, it is around 4%. So when you go to a party of 500 people, that means 20 people there standing are Thal minors. They don't know they are Thal minors. It is not a rare condition. It's a reasonable common condition.
Yes, sir.
So, and how many thalassemia majors are born in India? About 10 to 12,000 Thal majors are born in India every year. In which community, particularly what are those communities where thalassemia is more common or more prevalent?
It is more common in Punjabis, Sindhis, Bengalis,
or Gujaratis, Marwadis, Saraswat, God, all these. But now there is no community where you don't see thalassemia. There is no country in the world where you don't see thalassemia because of the migration of people and intercaste marriages all over. Everywhere we find thalassemia, thalassemia, and thalassemia. Okay, next we go ahead. Now, further. Okay, next slide.
These were the investigations done during this visit only.
Okay,
Uh,
fine.
hem- Hemoglobin was 8 and rest all things were fine. Serum ferritin was
Okay.
668.
So what do you think? Finally, you come to this conclusion. Probably this child is a non-transfusion dependent thalassemia with thal intermedia being. What are the other conditions included in anti-DT group?
The thalassemia intermedia and compound HB beta thal, and earlier HBH was also included in this.
HBH still is included in that. We don't include sickle beta thalassemia. Because see, sickle beta thalassemia, their presentation is different, their treatment is different, their management is totally different. So we don't include that in our thalassemia group. But all these three conditions which we have included in thalassemia anti-DT group, their presentation is same, their management is also same, except for thal HBE, where HBE, there is very peculiar thing about HBE that they can tolerate lower hemoglobins very well. And by the way, tell me, HBE, if a person is homozygous for HBE, what will happen to him?
The severe case would be.
You're just talking opposite of what happens to him.
Achha.
He behaves normally. Nothing will happen to him. So if both the parents are thal E minor, we don't worry. We don't go for antenatal diagnosis because, see, that is the peculiar thing about HBE. We have not been able to understand HBE very well. That HBE, you must be knowing, in our unit, we have one patient coming, HBE beta thalassemia. He has one elder brother who has never received same mutation, but who has never received
Any transfusion.
any transfusion. And this poor chap receives transfusion right since the beginning. He's been receiving transfusion. When he was small child, about I think 2-3 years old, he's been coming to us today. He's about 35 years. So HB is very peculiar. Homozygous of HB is asymptomatic or may have mild anemia. But when HB is combined with thal minor, then they behave like thal intermedia or anti-DT, or like our case, he behaves like thal major. Fine. So what are those factors which make homozygous or double heterozygote conditions milder? One you said is silent mutation.
Yes,
fine.
sir.
Next.
So if alpha thalassemia is also there along with beta thalassemia, then it will decrease the mismatch between alpha and beta chains and make the
What
disease
is the
milder.
basic pathology in thalassemia? What is the basic pathology in thalassemia? It is the
ineffective
mismatch of
mismatch of
alpha
chains.
and beta.
Beta chains.
If alpha is produced less, it is called alpha thalassemia. If beta is produced less, it is called beta thalassemia. So we are dealing now with beta thalassemia, which is more common in our part of the country. So beta is less produced, so alpha remains unpaired. That gets precipitated, and that causes oxidative damage to the red cell membrane, which has got a shortened life. What is the normal lifespan of RBC?
So 120 days.
Yes. In thalassemia, it may be 20 days, 40 days, 30 days, depending upon the type of mutation. Okay, what are the other factors which help in making the presentation milder?
The XMN polymorphism.
Okay, fine.
No,
or
sir.
yes,
Alpha, silent.
anything else?
Things.
One is XMN polymorphism.
Silent.
You said some mutations Others? And you yourself said if there are two beta plus mutations or beta plus plus mutation, milder mutations, they will present in a milder way.
Yes, sir.
Fine. HBE, we have already discussed that it may present like that or it may present like that. Nobody knows the genetic reasons for that. Or if a person is thal minor, but he has got triplication or quadruplication of alpha gene, means beta gene is produced normal, but alpha gene production is more. That will get precipitated and behave like thalassemia. Fine?
Yes.
Okay. Now you diagnose that 2.5 years thalassemia, intermedia or NTDT. Fine. I fully agree with your diagnosis, but how will you manage this?
So we'll give a intermittent transfusion, that is infrequent transfusion of 4 to 6 months. We'll start him on capsule.
Why? Tell me.
So, because the major complications with thal intermedia are because of chronic anemia or chronic hypoxia.
Okay.
So we have to manage that by giving infrequent transfusions. And we'll start him on capsule hydroxyurea.
Not infrequent. When do you give transfusion? I just asked you a very simple question. When do you give transfusion to thalassemia? We know, all books write, and practically also we have seen, transfusions are there. When you give them, they prevent all possible complications of thalassemia, intermedia or NTDT. Fine.
Yes, sir.
So, but you can't see, transfusions have their own problems. What are the problems with transfusions?
So iron overload, secondary iron overload, that will be there.
Or anything else?
Infections, aluminization.
Transfusion reactions. Transfusion transmitted infections, iron overload. There are so many problems. Arranging blood, giving blood, and all those things. So so before you put the child on this thing, regular transfusion, you must think twice. What are the indications of putting a child on, Gaurav?
Probably he is disconnected, no?
Yeah, I think he is disconnected. Even my is also disconnected. What happened to our site? TV?
Bhandari, Dr. Ravinder, are you there?
Yes, I am there. Where is Gaurav gone? Oh, yes, he has come back. So, Gaurav, can you hear me, Gaurav?
You are on mute. You please, yeah, unmute.
Sorry, sir.
Okay.
Hi, good evening, sir. Good evening.
Good evening. Gaurav, where did you disappear in between?
So there was some network issue. Sorry, sir.
Okay. Now you are okay. Can you hear me?
Yes, sir.
So what are the indications of transfusions? What are the various methods of treating thalassemia intermedia? One is waiting. You have to diagnose them very early. At the earliest possible time, you diagnose them. Then most important thing is monitoring of thalassemia intermedia. Because they don't receive transfusions, parents हमेशा ये सोचते हैं, oh, transfusion तो लगते नहीं. Even doctors also think that it's a very milder condition, so there's no need to monitor them. But if you ask me personally, when I see a case of thalassemia intermedia or non-transfusion dependent thalassemia, we are more concerned about him than thalassemia majors, because majors come to us very frequently. Every 3-4 weeks they come to us for blood transfusion. So हमारी नजर के तले रहते हैं, we can monitor them very well. But thalassemia intermediates, they don't come to us they usually come to us when they have already got some complication, which
Yes, sir.
not be reversible. Why I said that you are showing that in slide also, that thalassemia intermedia, nowadays we consider that it is a different entity. See the complications that we'll discuss this. Don't show this slide now. First, answer my question. How do you treat thalassemia?
So we have to give transfusions to prevent chronic anemias. And
Yes.
if child is having any
Just now I said that there is no consensus to put that. Though some people think that thalassemia intermedia should be given,
they,
there is no consensus in that. Most of the people feel that thalassemia intermedia should receive transfusion if
there
it
is
is
infection.
affecting their growth and development and all those things. Okay,
Yes, sir.
one. Second,
If there is any infection or in case of
yeah, during infection,
during
that
puberty,
is a short time. During surgery, before surgery, during pregnancy, during infection, all those things. But if there is a history of any this thing in the any coagulation defect, means a clotting defect, in fact, history of thrombosis in the family, then it's better to give them for regular transfusion for prevention of thromboembolic complications, because regular blood transfusion prevent thromboembolic complications, extramedullary hematopoiesis, pulmonary hypertension, leg ulcers, all those possible complications. But okay, second possible treatment.
So
you've already started him.
Yes, sir. On hydroxyureas.
No hydroxyurea, don't say hydroxyurea. Hemoglobin inducers, fetal hemoglobin inducers.
Yes, sir.
Fetal hemoglobin inducers. May we have maximum experience with hydroxyurea. We start them on hydroxyurea in majority of the cases. So, and we expect that it does increase fetal hemoglobin and increases their hemoglobin by an average 1
gram. Yes, sir.
So, but hydroxyurea is an anti-metabolite drug, you know.
Yes,
so
sir.
you have to monitor CBC.
CBC.
It can cause dose-dependent
myelotoxicity.
bone marrow suppression.
Yes.
Yes. And the dose that we generally start is 10 milligrams.
10
And if there is no effect, after about 8 weeks, we increase the dose to 15, and then 20 is the maximum dose. And most of the children. Hydroxyurea, one more important thing about hydroxyurea is, like blood transfusion, has been shown to prevent all possible complications of thalassemia intermedia or NTDT, like I just enumerated. Coagulation defects, pulmonary hypertension, leg ulcers, and all those possible complications. Liver, this thing.
Yes, sir.
What is that called? The extramedullary hematopoiesis, like pseudotumors also. Now, third treatment that you have for thalassemia intermedia, which I want you to discuss quickly. The time is getting over.
Splenectomy. The third thing.
Yes. Do you go splenectomy these days?
No, sir.
Can we go for splenectomy? Because we know that if you do a splenectomy in a child of thalassemia intermedia or NTDT, the hemoglobin will definitely increase by 1 or 2 grams.
But the complications would be more.
Yeah. What are the complications that a child with splenectomy can get?
The more chances of thromboembolic events and pulmonary hypertension, leg ulcers.
What is the lag period in the thromboembolic?
So almost 8 years, 8 to 10 years.
You must have read. Yes, it is 8. It is not immediately. So it gives a complication after years.
Yes, sir.
And then other complications of splenectomy.
Infection.
Why is thromboembolic complication? Why is thromboembolic complication more common in splenectomy cases? Because spleen is supposed to remove the abnormal RBCs,
yes.
charged platelets. They are circulating in the blood. So splenectomy increases the chances of all those complications which are prevented by regular blood transfusion, hydroxyurea. So nowadays, only very, very necessary if it is, we go for splenectomy. Otherwise, we avoid splenectomy. What are the indications for splenectomy in thalassemia case, intermediate cases nowadays?
If
Important ones.
Hypersplenism causing thrombocytopenia, leukocytopenia, and symptomatic splenomegaly causing abdominal symptoms, of if the transfusion is raised more than 200 to 220 ml.
That is for thal major. Here we are not giving thal regular trans. Why are you saying that?
Yes, sir.
There are 2-3 indications. One, there is
Overgrowth.
hypersplenism where there is cytopenia. Second, if the spleen size is very big, more than 18-20 centimeter, there is risk of rupture of spleen. Or if the spleen is causing pain in the left hypochondrium or causing satiety, pressing the stomach,
yes, sir,
then in that case only we remove. Or if blood transfusion and chelation is not possible, we may try in those cases. Okay, now we come to the our case. That, see, you said he has been started on regular transfusion. Why now? Though he is maintaining good hemoglobin. Though he is maintaining good growth, I told you at that time, remember that this child has got not a very grossly retarded height and weight.
Yeah.
Why have we started on?
Because of puberty, there's increased
Yes,
demand.
some people believe, and I also believe, that in the peripubertal period, if you increase their hemoglobin, see, he has been maintaining his hemoglobin between 7 and 8 grams.
Yes,
So
sir.
if you maintain low hemoglobin, his growth during puberty will be less, and development, pubertal development also will be delayed. So to enhance the whole thing, to make it, to bring it up to the near normal, we give them regular blood transfusion. And once they have achieved, we may go back to the original thing.
Yes, sir.
Okay. Okay. What are the possible complications? Now you come to the slide which you showed. No.
Sir.
Yes. So why it is called a different entity? Because thalassemia major. What are the causes of complications in thalassemia major? What are the problems in thalassemia major?
The iron overload, secondary iron overload, ineffective erythropoiesis.
Yes, the main inevitable problem which is unavoidable is iron overload, and second, all possible complications because of blood transfusion, blood reactions, and then iron, of course, is there. Each unit of blood gives how much iron?
Almost 1 gram, 1 milligram.
1 gram.
1 milligram.
तुक्का नहीं मारते एग्जाम में कभी भी, याद रखना. It may go against you. 200 milligram per 200 to 250 milligram per unit of blood. Remember that. Okay. How much blood do you need to increase 1 gram of hemoglobin in a child per kg?
To increase one,
Roughly 5 ml per kg. 5 ml per kg will increase by 1 gram. So to increase 4 grams, you give them 15 to 20 ml per kg every time. Okay. Now coming to that, so the complications of thal major are related to blood transfusion and iron overload. But in case of thal intermedia, they are mainly because of
chronic
ineffective chronic hypoxia caused by ineffective erythropoiesis, and ineffective erythropoiesis also in turn causes coagulation. It is believed that people say that if you get MRIs done for thalassemia intermedia, you may find many of them, up to 10%, having silent infarcts in their brain. You may not come to know these infarcts. Okay.
Yes, sir.
So these are the possible complications. You have cholecystectomy is because of gallstones that you have to do. Gallstones are because of. You see, one more practical thing.
Hemolysis.
Thalassemia majors who is on regular transfusion, you will not find them icteric. While thalassemia intermediate, because in them hemolysis keeps on going there, so they may be icteric and gallstones. That's why they are formed. Extramedullary hematopoiesis, more common, yes, but you see extramedullary hematopoiesis at what age? Do you see in younger age group?
No, sir, after 10 years of age.
No.
Five.
No, after 30 years, 25, 30, 40 years, you see. It is very late onset, but once it is more common in dorsal vertebra, paravertebral masses are there, and then it causes compression on the nerves and patient may come with paraplegia. The treatment for that is hydroxyurea, of course, you give them, and then what else? Come on. Radiotherapy.
Radiation therapy.
And in severe cases, to relieve acute symptoms, surgery also may be required. Leg ulcers, very common. We see very often leg ulcers come in thalassemia. These are chronic ulcers. They are called non-healing ulcers. And what is the treatment for that? Remember, one thing you can say blindly for all these complications, one treatment is to put them on regular blood transfusion. Maintain their hemoglobin above 10. And for leg ulcers, we give them hydroxyurea.
Hydroxyurea.
Or you give them antibiotic cover. There are other options available. People can and people have tried, like vasodilators. Some people have tried oxygen chambers to keep their leg in oxygen chambers for there are multiple sittings, then bone grafting. But I have seen nothing works except transfusion, hydroxyurea, leg raising, and regular bandage. It takes few months to heal. Thromboembolic events, I have told you, it may occur. Venous embolisms are more common, and it can occur in legs also. Sometimes brain infarcts, we have seen they come with infarcts, or sometimes there are smaller infarcts, less than 1 centimeter. They're called silent infarct without any symptoms. If you get pulmonary hypertension is very common. And what is the treatment for pulmonary hypertension?
Regular blood transfusion.
Yes, one is regular. I have told you blindly, you can say for everything. And then specific treatment is?
Sildenafil.
Yes, sildenafil. Or bosentan is another medicine which is available. That just sometimes helps them. Or diuretics you give them to reduce the pressure. Then endocrine abnormalities are less seen in thalassemia. Okay, thalassemia intermediate, though they can. The more important is liver. You're not mentioned in this. Liver, these children get liver iron overload. They don't get cardiac iron overload. That is the most important thing. That why? Because their source of iron is mainly, barring few transfusions, they may get CIT, gut. And in that, they're in the portal, periportal cells and hepatocytes, their iron is absorbed, stored, and liver gets overloaded. And sometimes they get cirrhotic, and hepatocellular carcinoma is one of the important causes of death in thalassemia intermediate cases. They don't get left side failure, they get pulmonary hypertension in these cases.
Yes.
Okay. Right. That's why I said that they should get hepatitis A, because they are likely to get iron overload also, and that will add to the problems. Okay.
Yes.
With that, I think we have covered practically everything about thalassemia intermedia. If anybody has any questions, let me see the chat box. Okay. Right. If anybody has any comments or any questions or anything, please. Any of the faculty people? Any faculty colleague wants to ask anything? Gaurav, you want to ask anything? You want to clarify anything?
No, sir.
Okay. If there are no questions, I hand over to Dr. Bhandari if he's there. Dr. Bhandari?
Good evening, sir. I think Dr. Bhandari asked me to give the vote of thanks because he was somewhere stuck up in some DMA or he just left. I think Dr. Ajay also left the webinar because he has to attend some CIP meeting. I've seen his message. So I'm Dr. Ravindra, PG coordinator for Delhi IAP.
Right, sir.
All of you.
Any comments that you have, sir? Anything?
Sir, no, that's very informative, very good. Just because you have covered all the thalassemia intermedia with, management part and treatment part. As nowadays, you have just revolutionized the treatment of thalassemia in the form of BMT. So, any such type of role in thalassemia intermedia or any such kind of therapy?
There is no consensus on BMT in intermedia cases. But personally, in many meetings, I have advocated because I have seen them suffering so much when they grow to the 20s, 30s like that. So I personally feel whether it is thal major or intermediate, you don't know how he's going to behave later on. So that is my personal opinion, but there is no consensus as such. People, even TIF has not talked about BMT in thal intermedia. But I personally feel that if the parents are agreeing and we tell them the possible complications that they can have, I have seen a lot of complications in most of the thalassemia intermedia. That's what I said just now, that when I see a thalassemia intermedia, I get more worried than thal majors because these thal majors, they keep coming to us regularly for blood transfusion so we can pick up their complications early. But thal intermediates, they don't come. So they come only when they develop serious complications, and that may be life-threatening also. So personally, I feel that they should go for thal in bone marrow transplant, but nothing official about it.
Okay, thank you, sir. Because because this is very interesting. For example, I'm at Hindurao Hospital, so we have a thalassemia unit, and we in our thalassemia unit, majorly it is thalassemia major, and we have more than 80 patients. More than 80 patients are in our follow-up, and luckily, because of the All India giving grants, almost 20 of our patients they have gone for BMT. And because
that is probably because of Coal India.
Yes, yeah, Coal India. So Rajiv Gandhi is doing some part. Rajiv Gandhi then they are against. So now
All India, Rajiv Gandhi, even Gangaram is also getting realized.
Okay. So, sir, what I have seen, because rest of the patients I have seen many complications, because my area of interest is endocrinology. So I have seen that couple of them have developed diabetes, which is very unfortunate. Many of them, they are more than 10%, they are of short stature. Equal amount of number, they are having delayed puberty.
Yeah,
so all of these complications,
they don't.
All of these.
Yeah. So that is because they don't maintain good hemoglobin.
Very true, sir.
And in less than 1,000. I have got, see, in our unit, we have about 178 cases, and I've got more than 90 cases adults. 23 of our patients have got married, and 9 have children also. Which they are working, they are earning for their family, they are doing everything. But one thing good about them is that they are maintaining hemoglobin less than 1,000 and, ferritin less than 1,000 and hemoglobin above 9 grams.
That
And
is
in
so.
fact,
So,
I've seen that
as
those who get married, they become very serious.
okay, okay. So the
They
same.
feel their responsibility.
That's good, sir. That's good.
Sir,
And the same
you were saying something?
complication you just said it may occur in intermedia also.
No, thalm intermedia, they come to us like with thrombosis. They will come to us with pulmonary hypertension. So many of these conditions are not reversible.
Very true.
They'll
So
come
this
to us
can
with
be.
liver damage. See, one day we
Okay.
had a case who had come to us with cirrhosis.
Okay. So this can be prevented by
That
BMT.
we had to monitor every 6 months. At that day, BMT is not possible. See, the BMT, the general principle of BMT is the younger the better. The best age
Younger
for
the better.
BMT is 2 to 6 years. After 10 years, even
Very
Coal
true.
India, we have allowed up to 12 years. After 10 years, we
Yeah,
don't
up to
give.
12. Yeah.
After 12 years, we don't give permission for BMT.
Very true. So anyway, thank you, sir. Thank you very much. They're very learning tips for me and my PG. They are among the audience. So thank you very much.
Thank you, sir. Thank you. Thank you for your kind words. Okay. So we close our discussion here. There are 2 questions in the chat box. We have discussed thalidomide rule. Hello?
Yes, sir.
There is one question in the chat box, role of thalidomide. I did not purposely touch the topic of thalidomide because thalidomide is not yet. There are few papers, many of our patients are using thalidomide. It does give relief, but thalidomide is not officially approved as a medicine for thalassemia, major or intermediate. People are using off the shelf, but I cannot say because I don't have much experience. I used only in 2 cases. Those were gone cases. In fact, at a desperate attempt, I was losing them. We couldn't do bone marrow, and they have developed severe allosensitization. You know, allosensitization is those less commonly transfused, or those who start transfusion late, or when you give first transfusion or transfusion during pregnancy. So all thalassemics should get fully phenotype matched blood. Okay.
Yes, sir.
Anybody else? Anything?
That's all.
Thalassemia as such is a thrombogenic condition. Okay, we close this discussion here.
Yes.
Thank you. Thank you, everybody.
Thank you so
Bye.
much.